Chapter 27 is going to focus on behavioral psychiatric emergencies, suicide patients, how to approach these patients, what kind of cares that we can deliver for these patients. These patients are quite a challenge, especially pre-hospital, but they should be seen as patients that have a medical condition, just as you would for your cancer patients, etc. This is a medical condition and can be a true emergency. So I'm going to play a video for you. It doesn't usually work here. Let's see if it does, which it won't. So we're going to switch over here to the recording. And I want you to see what you would do. This is quite lengthy.
Auto gave me 911.
Hi, something's wrong with my son. I'm on 1103 South Jefferson. I don't know whether he got, he's 29. I don't know whether he got onto something. He's just, very strange.
Okay, does he need an ambulance? What are you reporting?
I don't know. He's just talking and talking and saying he's going to die, and he's just making like he's on something. I don't know. You hear that?
Does he live there?
Huh?
Does he live there?
Yes.
Has he been drinking?
I just got home a little while ago, and took a shower. He was sleeping. I think he must have.
Does he use drugs?
He used to. He hasn't for. He used to do marijuana. He hasn't for years. I don't know whether. I don't know. I don't know what's happening.
I mean, he keeps yelling and says he's dying. Does he say anything else?
No, he just says, I'm dying, Mom, and he's sitting there naked. He certainly doesn't do that in front of his mother.
Okay, we are dispatching help, okay?
Yeah.
I want you to tell me if he does anything else.
Yeah, he's just kind of sitting on the floor screaming.
But you don't know if he's used any drugs?
I don't know.
Okay.
It sure looks like it. I don't know.
You want to know about it, Mom? You want to know about it, Mom?
Jimmy, I'm getting you some food.
I know about it, Mom. You want to know about it, Mom. You want to know about it, Mom. You want to know about it.
9128 and 9218.
9128. 9218.
You can help out with a southern complaint. RP's 29-year-old son is acting strange. He's yelling and is currently not having any clothes on. No weapons, unknown intoxicants, unknown drugs. Keeps screaming that he is dying. He's breathing heavily and has no clothes on. Code 3.
9102.
Go ahead.
Dispatch Gold Cross, non-emergency at this point, just to stage in the area. Give them the behavior signs we have at this point. I'll be around as well. Can you talk to your caller, just see if he has any past drug history or mental illness history?
9102, the only thing the RP is aware of is he used to use marijuana years ago.
Okay. I'll be in the area.
I'm clear.
What?
Pull me all with 102.
Hi, it's okay. It's okay.
As I'm not.
It's okay.
As I'm not. This is the last heartbeat.
It's okay. It's okay.
But I'm going to
I understand.
not. Is it gonna die? But I'm going to. Is it gonna die? But I'm going
You're
to.
okay.
Is I'm going to die?
9102 restrict traffic.
Beats.
But
It's okay. What is his name? Tim?
Die.
Tim, we need to go to the hospital.
But I'm going to.
9102.
Wow,
Have
and
Gold
this is
Cross
a
come up
really
to the
weird one,
address.
because I'm
1033
not
at this
die,
point.
But I'm gonna hear the heartbeat.
Yeah.
Of
What's his
me
first name
saying,
again?
Oh, I'm going to die.
Tim.
But I'm going to lay down on the ground.
Can you lay down
as
for me?
I'm going to die. But
Tim.
I'm going to
Tim.
not, and you understand now. And isn't that fucking weird? But I'm going to
Tim.
is I'm gonna die, but I'm gonna look around as
Tim.
if I'm gonna die. Shivers are gonna kind of running up my
Tim,
side.
it's okay,
And I'm
ma'am,
not gonna be
ma'am,
able to say that,
ma'am.
but you're gonna
At
know
this
what
point,
I'm
let's just
gonna
put the
mean.
clothes away.
And I'm gonna
Okay,
lay down
this is
on
a
the
reaction
ground
to
with my arms
something.
shaking
Okay,
to
we'll
make
get
it
him to the
look like I'm
hospital.
really-
9102.
I did see someone
Go
in
ahead.
the yard.
Advise Gold Cross, I believe we have an excited delirium case. I need them here.
Last time when this one's gonna happen, and I'm gonna fart really gonna happen. This is gonna happen.
Tim, it's okay.
Last time I didn't know this was
Just relax, man. Just relax.
really gonna fart, and I'm gonna happen in that hand right there, and I'm gonna really gonna fart in it. And this one, wow. And the heartbeat is coming.
We get two to the back and kind of come in that entrance, officers. Okay, in case we have some movement. I eventually, yeah. I think what we're gonna do is if we get those two to the back and get them in here, once we do go hands, they're probably gonna have to go to the feet, and then we'll get them on board. We have the medics ready.
Yep.
Okay.
They're at the sideline.
All right. All right. Let's move. Okay. All right. Just relax. Okay. Get the medics up. Let's get him on.
Get the medics
Strapped down to the cot.
We need you to
You guys
relax,
got your
okay?
medicines?
Okay, take deep breaths.
Are we not going to do that?
We need you to breathe.
Hey, what's going on?
It's all right, man. You've been gonna rest. Did
Did you take anything? No, yeah, Narcan and Helbo. Or, yeah, Helbo.
Tim.
Let's do a hep lock.
Are you just gonna do it?
I'm gonna draw it.
I am.
Yep. She said she saw mushrooms in the yard. So
Get on his legs. Lay across his legs. There.
And why not?
You want to go on a board with him and then strap him and then get him out, or what do you think?
I think if we can wrap him in this blanket.
I just don't want him to get free if he.
Yeah.
Yeah.
Have him get the scoop stretcher. We can do that.
Sure. As long as we can secure him to him.
With straps. Plenty of straps.
But I'm gonna grab my balls.
What?
But I grab my balls one last time. It's okay. I can hear this one. It's weird. Even though it's okay, I'm gonna grab my balls. That okay? Though?
Yeah,
Isn't
we
that
got to get you to the
okay, though?
hospital.
Isn't that okay? Please,
help
and I
you
tap
out.
my hand. Please, and I tap my hand. Please,
No.
and I tap my hand.
I'm
Please,
just-
and I tap my hand. And
No, it's okay.
Please,
Don't fight it.
Please, and I tap my hand. I fought. Please, and I tap my hand. I fought. Please, and I thought.
We're gonna
Please, and I
get
taught.
you to the hospital.
Please, and I
Tim.
taught.
Relax.
Please, and last time I
Relax.
shook and I taught my. Please, please,
Tim, we're
please,
gonna-
please. And last time I, please, and last time I grabbed my balls and I.
Tim,
Please,
stop.
and last time I grabbed my
Stop.
balls and I shook. Please, and last time I grabbed my balls and I shook. Please, and last time I balls and I shook.
You want
Please, and
to roll him
last
up
time I
and try
grabbed
to
my
get him
balls
on
and
it?
I shook. Please, and last time I, please, and last time I, please, and last time I,
Over this.
please, and last time I shook and I grabbed my balls.
Tim.
Please, and last time I shook and I grabbed my balls.
Relax.
Please, and last time I shook and I grabbed my balls and I shook.
Tim,
Please, and last time I shook and I grabbed my balls and I.
Yeah, that's fine.
I'm to the bus, come on, I'm to the bus, come on. I'm to the bus, come on, I'm to the bus, come on. I'm to the bus, come on, I'm to the bus, come on. No, I'm serious. No, I'm serious. This
Like
is
I
what I'm
said,
about, though.
like I said,
No,
if
I'm
you're-
serious.
It's okay.
I'm serious. I'm fucking serious. This is what I'm about, though.
I hear you.
No, but I love you guys, though.
It's okay.
Oh, this
It's
is
all
what I'm
right.
about.
It's all right.
Oh, this is what I'm
We're doing
about.
good.
This is what I'm about.
We're doing
This is what I'm
good.
about. This is what I'm about.
We're doing good.
Don't kill me. Don't kill me.
Nobody's gonna hurt
This is
you.
what I'm about. This is what I'm about.
Nobody's going to hurt you.
Come on. Come on. Come on.
Nobody's going to. Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax.
Kaboosh.
Just, we're good.
Kaboosh.
Tim,
Kaboosh.
Tim, you're all right.
Kaboosh. Kaboosh. Kaboosh.
Tim, you're going to hurt yourself.
I don't want to die, though.
You're not going to.
Seriously,
We're going to go to the hospital, bro.
Seriously, though.
We're going to go to the hospital.
No. This is what I'm gonna.
Did that break loose?
This is what I'm gonna die, though. No.
Tim, relax.
Tim, relax. It's okay. Yes, it is.
Not okay.
It's okay.
It's not okay.
It will be okay. You got to calm down.
Not okay.
You got to calm down. You got
This
to
is gonna
calm
die.
down. No, you're not.
It's gonna die.
We're going to the hospital.
This is gonna die. This is gonna die.
We're going to the hospital.
No.
Tim. Relax.
No.
me a
This is
favor,
gonna
man.
die, though. This is gonna die, though.
Remember, your mom's all worried about you. Try to relax so we can help you.
Mom!
That ain't gonna.
Don't let him kill me! I love you, but this is gonna die, though.
Okay.
This one. All the meat I've eaten, I forgive myself.
Are we good on those arms?
This is gonna be it. I'm in it.
Satisfied?
Mom!
I mean,
Mom! Mom!
Should I do a handcuff also loose in case? of a safety
You're
mechanism
questioning
from that?
liar! You liar!
All right.
Liar! 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 You're the one! Liar! You're the one!
Let's get him out of here.
Poke his back with a shovel! Poke his back with a shovel! Grab a shovel! We have a shovel in the backyard! Grab a shovel and poke his back out! Mom, grab a shovel! Poke
You got it?
Yep. I don't want to kill you.
You don't want to kill me?
I don't want to kill him. Okay, I don't want to kill him, but
We're trying to take care of good care of you.
me or you.
Oh, no, we're
All right. So just seeing a patient that out of control is tough. Probably a case of excited delirium on board. What would you do? So we need to talk about what we're going to do. You're going to run into things like that. Just remember that your utmost importance on that scene is your safety. Okay. Your safety, your partner's safety, and then the patient's safety. So behavioral emergency is defined as a matter of a person acts that's unacceptable or intolerable to that patient, the family, or the community as a whole, right? Everybody's got to be safe. We can't be leaving patients out of control, potential harmful to them, to others. So how does this behavior, how does this happen? How do these emergencies happen in the human body? There's a lot of study going on with these and different presentations, but basically, you know that behavior is controlled by your neurotransmitters in the brain, and something, as far as a synapse, something is misfiring. So neurotransmitters, or lack thereof, have been kind of implicated here in these depression and other behavioral disorders. Medications are designed to kind of enhance those neurotransmitters, and try to, there's other medications also that are trying to inhibit some of those behavior, the behaviors that are unacceptable. So some are caused by, yes, psychiatric conditions, mental disorders. 1 in 5 adults in the United States do have some sort of mental disorder. So we are seeing this population in pre-hospital care quite regularly. Another challenge we have is the mental health services have been declining, overcrowded. Most of these patients are in the community with very minimal treatment. So therefore, we're going to be pretty common initial providers of these patients. So physical causes of altered mental status. So we do have to take this into consideration, right? Sugar, water, oxygen, and very important. Any impediment of that's going to cause some behavioral issues. We already discussed diabetics and their low blood sugar. They can present as combative. Hypoxia can definitely do that. Head traumas, seizures, drugs, alcohol, stroke, temperature extremes. So we need to make sure that this mental status that we're seeing is a behavioral emergency and isn't being caused by some sort of imbalance that we could fix. We may see some situational stress reactions. We were discussing trauma, cardiac arrest. You've got some situations where people's behavior may be quite different on these scenes versus if you saw them out in public with no stressful situation going on. So situational stress reactions, we're going to be on scene for a while. Okay. Calm creates calm. I'm not telling you to just accept all their behavior and they're lashing out. However, you do need to be mindful of the situation they're in and know that more than likely this is not their norm. Okay, so keeping your emotions under control. We're not going to fight with patients, argue with patients, listen to your patient, and first and foremost, be watching their presentation, making sure that your safety is number one on the list. Acute psychosis, acute meaning fast onset, a break in that patient's ability to function on a quote unquote normal basis. Some psychiatric disorders we see, schizophrenia, This hallucinations, they're seeing things that aren't there. They're delusional. They think people are after them. Catatonia is a state where they're just basically in that stare presentation. The video we watched, he had pretty much all of that going on. And once again, because we don't know how these people are going to react, we need to make sure that we're watching each other and making sure that's safe to present to our patient. So as far as care goes, we're going to have a bunch of presentations. So whether it's they're withdrawn, they don't want to talk to us, I don't want to say anything. You may get ones that are very talkative, very agitated, pissed off at you. Bizarre behavior like we saw in that video, threatening behavior, or wanting to harm themselves or others. They want to harm themselves. They're not going to have an issue harming you. So make sure that you're staying safe. Identifying your partner, your role there, slowly, clearly make eye contact, listen to that patient. We're not going to judge anyone. And we're going to try to build that trust. Make sure you're getting that nice distance from the patient, using restraint if we have to prevent harm to us and to them. We'll go through restraints in a little bit here. So scene size up, very careful, right? Making sure before we even enter that scene has been declared safe. That patient is most of the time we're gonna have police presence there for sure. Identifying your role, complete your primary as best as you can. Keep in mind that your mental status is altered, but your ABCs, if they are screaming at you, shouting profanities, you have an adequate airway, breathing, and circulatory, right? So I'm not trying to do that as a joke, but we don't have to get too much farther into that. Okay, so we're not going to go in and try to do invasive measures or any treatment when we have an agitated patient for sure. If we can do a detailed exam, great. If you can't, just make sure the ED knows that they were not cooperative when you were on scene. And getting a history, is this patient on any medications? If you see any around, if there's relatives, like his mom was there explaining that there was some drug history on board. So getting that history is beneficial. Unusual, agitated speech pattern. You notice that he was kind of growling. That's called keening. He was in excited delirium. Naked, they take all their clothes off. They're hot. They're just very bizarre behavior. They'll be shouting out things like he did that really weren't making sense to what was going on. You could see he was kind of trying to reason what was going on. You heard him say, "I love you guys. I know you're here to help me. I won't hurt you." You can't trust that, but just knowing that he's got all of these thought patterns going on and you just can't sort out, reality from what he's experiencing. So spending time, do we have medical or traumatic causes on board that's causing this altered mental status? If they want to discuss feelings, that's great. We're there to listen. We do not play along with any hallucinogenic stuff. They see things that aren't there. We're definitely not going to be playing along with that. Considering involving the family or friends, this can go bad, this can go good. So however it's presented, be mindful of that. Sometimes the family's causing more agitation than good. Sometimes, just like his mom was kind of keeping him somewhat under control. So just take that into account. Your suicidal patients, it is the 10th leading cause of death in the United States, especially in that combat veterans, senior citizen population. If emotional distress is severe, your patients can, have thoughts of suicide. Some of the following possibilities that are big, depression is a big one, high stress levels, of course, any emotional trauma, breakup, divorce. Your populations there, 15 to 25 and 40 plus, 15 to 25 being that tough peer pressure age category here, relationship category. And as we age, of course, with pain and with, our patients becoming elderly, the kids leave home, they might lose a spouse, depression's a big thing. So drug or alcohol abuse on board as well can be contributing to this. All right, so sorry about that interruption, drug or alcohol abuse. Um, is there threats of suicide on board? Do they have a plan? Have they attempted this before? So this is kind of your OPQRST with these behavioral or these suicide intervention, these patients. So your own safety, of course, is of utmost concern. Providing a scene size up, treating those life threats, if you can. But like I said, if they're screaming and hollering and yelling, your ABCs are okay. So keep that in mind. If you cannot do a physical exam, it's understandable if it's not safe. And make sure that you're calling ahead to the hospital and letting them know that we do have a behavioral crisis on board. So if we need to have security meet just for preventative measures, that can all be lined up. So let's see here. We've got a 23-year-old male. His girlfriend called 911 after a domestic dispute. He's uncooperative, refusing some treatment. The girlfriend says that he's depressed and he's suicidal. He owns a gun and he's threatened to shoot himself. So some things I want you to consider. Can you treat this patient if he was not the one to call? Should you believe the girlfriend? Does the patient ultimately need treatment or transport? And can you treat and transport him against his will? What should you do? So taking this into account, it could be a he said, she said thing. So we're definitely going to try to persuade him to seek help if he does have depression on board. Ultimately, he's not posing a threat. He is posing a threat, but he's just uncooperative. He doesn't want to be treated. If he's alert and oriented, he has every right to refuse. We can't just take him just because the girlfriend wants him to be taken, but we would definitely want to spend some time on scene, talking with this patient, seeing, what's going on, getting his side of the story, and, possibly trying to urge him to seek some help to maybe straighten out some of this. So aggressive, hostile patients, if we're going to have to do a restraining type situation, physical restraint, make sure we've got enough bodies. You at least need to have 4 plus probably 1 talking to him, 1 for each extremity, and 1 that's going to be basically the distractor, the one that's discussing with him. Make sure police are on scene for this, and that everybody knows their role, because this is going to go quite quickly once we do need to take him down and get him restrained. And we will do some of that in skills. So dispatch, anytime you're on a standby and you get called for a standby, you want to make sure that you're just think that, that scene is not deemed safe. They're telling you standby for a reason. The scene is not safe for you to enter. So therefore it should raise some red flags with you, regarding what could possibly be going on that scene. All right. Make sure that we have an escape route. Never let that patient get between you and the door. Don't threaten that patient. Watch for weapons. If don't feel like you're being rude by wanting the police to pat down your patient prior to them entering the ambulance. I would, especially if he's a very hostile, or he or she is a hostile patient. You may not be able to go past that primary until that patient's restrained or calmed down. And you're going to spend a lot of your time trying to get that patient calm, cooperative. So hostility, aggression, never an excuse for not assessing patient, but the way you go about assessments is going to be a little different with these types of patients. So scene size up, scene safety. If you need ALS for chemical restraint, please request that. Watch for changes of behavior. You cannot trust this. Some of these patients can really talk to you and say, just let my arm out. I'll be cooperative. I just need to have freedom of my arm. You just cannot do that. Okay. You've got to keep yourself safe and the patient safe. So reasonable force, restraints, you're going to need to follow your protocols as to whether you can do this or not. Based on the patient's size and strength, what type of behavior we have on board, what's your mental status, what tools do you have? The ones that they're showing here are called POSI, Velcro restraints. They're pretty strong. Most of the time, this is within our jurisdiction to do, but check your protocols. You're still going to make sure that these patients are properly cared for, make sure that you're not having any constriction where they're not getting blood flow to the extremities, and that you're still doing your ABCs. So excited delirium, extremely agitated or psychotic behavior. This is what our patient earlier in that video was presenting as. Triggers can include uncontrolled psychiatric illness if they have failed to take their psych meds, or I believe at some point in that video, they said he was taking mushrooms. They can develop significant life-threat cardiovascular since they are in such a high physical state. The heart rates are way up. And you really need to watch these because they can arrest. That's a pretty good outcome if this excited delirium is not controlled. So we're going to go ahead and play another excited delirium video from the Seattle Police Department. It's kind of long, but it's pretty beneficial for what this gentleman's presenting as far as excited delirium and what to look for and how we're going to assess these patients. So.
Excited delirium is new to the law enforcement community, primarily because of the rise in the use of illicit stimulant drugs and also because of the closure of many inpatient psychiatric or mental facilities. As early as 1849, it was known as Bell's Mania and used to be the domain of doctors and inpatient psychiatric clinics. That's primarily where you saw it. As these people have moved from an inpatient clinical setting out onto the street and begin self-medicating with illicit drugs, it's now becoming the first responder that has to deal with this syndrome. The current published medical definition of excited delirium is a state of extreme mental and physiological excitement characterized by extreme agitation, hyperthermia, hostility, exceptional strength, and endurance without apparent fatigue. In many circles, this is also known as in-custody death syndrome. We're not expecting officers to become diagnosticians or medics, but we do want you to be familiar with the different signs and symptoms of excited delirium as a medical crisis so that you recognize when somebody needs medical intervention. They're acting out, they're violent, it looks like it's a hardcore law enforcement problem. But the problem is we have no way of knowing where they are in this syndrome. We don't know if they've just started a binge or if they're circling the drain waiting to die. And we certainly don't want them dying in the back of your police car. So if you recognize this as a medical crisis, you can call the appropriate medics, we can get the medical intervention, and if appropriate, transport them to the hospital. The main reason that we're seeing this now more than ever has to do with a combination of two things. First of all, stimulant drugs are still out there and their use seems to be rising. Stimulant drugs by themselves in a one-time shot are not going to induce this. This is stimulant drug use over a period of time. We're seeing a lot of cocaine out there, a lot of methamphetamine, and those seem to be the primary culprits. The other factor is mental illness. It can be either stimulant drug, mental illness, or a combination of the two. It used to be that people who had a severe mental illness were institutionalized under the care of a doctor and they were administered their medication at regular doses. As the emphasis in the mental health medication, if they're not taking their medication, they begin self-medicating with stimulant drugs, it's possible that they're going to find themselves in this condition of excited delirium. That means that we as first responders, the police, the firefighters, the emergency medical technicians, are going to be the first point of contact for people in this potentially life-threatening medical crisis. One of the visual aids we're going to use is to show you a video. We commonly refer to this as the barbershop video. In this, we have a person who's in the classic state of excited delirium. Just to set it up, this person's naked, showing signs of hyperthermia, which is elevated body temperature. He's sweating, he's shouting incoherent phrases. Other times you'll see somebody that's making animal noises, known as keening. This person's already been shot by the property owner, so he's got apparent insensitivity to pain. He's not feeling the fact he's been shot. The officer's using a lot of body weight to try and hold this person down, and it's having no apparent effect because he's exhibiting superhuman strength. So somebody who's suffering from excited delirium, you could see extreme agitation, disorientation, or paranoia. You might see hyperthermia, which is overheating, in the form of them sweating, seeking water, or stripping off clothing. Bizarre and or aggressive behavior, shouting of incoherent words or phrases, or keening, which is making animal noises. You may see lid lift, which is the eyes open wide so you can see the whites all the way around. Paranoia, panic, violence towards others, attraction to light or glass. It's not uncommon for somebody to attack the lights of a patrol car or break out glass. Unexpected physical strength, apparent insensitivity to pain, and sudden tranquility is normally a danger sign at the very end. In this video, where we see the man wearing only socks, the things to note are the cooling behavior. He stripped off all of his clothing and is wearing nothing but a pair of socks as he's walking down the street. He has a strong attraction to the lights of the patrol car and in fact chases the patrol car for about 15 minutes. In this third video, you'll see a man standing in the middle of the street. When the officer approaches him, he becomes immediately aggressive, takes a swing at the officer, and he's combative. He then goes on to strip off his clothing, which is a sign of cooling behavior, trying to cool his body down. From there, they deploy the taser up against him at fairly close range. For most of us, that's going to be painful enough to drop us to the ground. In his case, you can see insensitivity to pain as he tries to fight through it. Eventually, he goes to the ground, but he's not impressed by it. He's not feeling the pain, and he's got this superhuman strength as he continues to try and fight through it.
Get on the ground now! Legursky, bring me the taser, 500 block 11. Get on the ground! Get on the ground! Quit fighting! Stop! Lay down! Roll over! Roll over!
When patrol responds to an incident like this, we want you to, first of all, worry about your safety. If you can assess this person from a distance, don't approach until you have enough resources. Get as much backup as you can to approach this person safely. You're not always going to be able to do that. If he's endangering others, you're going to have to go in. The idea is that we want you to use enough control tactics that you bring this person under control as quickly as possible. That way we can get the person restrained and delivered to medical intervention as quickly as possible. Once law enforcement becomes involved, if we have to intervene, we certainly don't want somebody dying in our custody if we can prevent it. We've established a new protocol with the Seattle Fire Department. If we request a medic response for a violent subject, that's supposed to trigger a Code 7 response, meaning they're going to send us the crews to assess the scene, but they're also going to roll medics. Those medics now have an unusual protocol, meaning that they're now allowed to sedate subjects in the field if it's appropriate. That means that in order for them to sedate them, you're going to have to restrain them. They're going to need a limb or something holding still long enough to inject it with the sedative. Once that's done, they're going to assess the person and, if appropriate, transport them up to medical intervention.
Put your hand behind your back. Put your hand behind your back. Put your hand behind your back.
In the context of excited delirium, this period of peril is that moment from the time the person stops struggling for about 5 to 10 minutes afterwards, because that is the time period where their adrenaline levels are falling, potassium levels are potentially rising, and this acid level they have in the bloodstream is especially dangerous to the heart. If they're going to die from this, chances are they're going to die in that very first 5 to 10 minutes after the struggling stops. Normally that's when we as police officers are dusting ourselves off and picking up our equipment, but we need to have somebody specifically monitoring the subject during that time. If you can transfer them to medic care during that period of time, even better, because they're better equipped to monitor the person. The medic response is going to be your judgment call as the officer. If you're out on a Friday or Saturday night and you have normal, typical bar behavior, people who are getting drunk, they're getting rowdy, maybe they're stripping off their clothing, but it's controlled behavior. When you show up, their behavior modifies. That's probably not what we're talking about. We're talking about when you show up and you see somebody who's very aggressive, they're not responding as you would expect. That's the time to begin to suspect perhaps there's something more going on. Perhaps we're seeing an actual medical crisis. If that's the case, call for a medic response for a violent subject, get the medics on scene so that they can evaluate this patient. Well, there are several different ways we can initiate this excited delirium protocol that we talked about. The dispatch center is actually training each of the operators, or they're in the process of training the operators on what to look for and what questions to ask. If they suspect that this may be an excited delirium episode that they're getting calls about, they're going to get a fire operator on the line at the same time so they can ask the medical questions and determine if a joint response with fire is appropriate. If so, they're going to initiate that at the dispatch level, so we'll respond with fire. If, on the other hand, you arrive at a scene and you're seeing things that aren't quite right, that are looking like these videos and sounding like these points that we pointed out to you, go ahead and from a distance begin calling for your backup, if you can safely, and go ahead and get fire rolling your way so that they're on scene to sedate if appropriate and give medical treatment if appropriate. If you suspect somebody is suffering from excited delirium, your goal, once you can do it as safely as possible, is to restrain the person with a minimum amount of fight. The more they fight, the greater the chance of a negative outcome. Having said that, one of the quickest ways to restrain somebody who's under the influence of excited delirium is to go ahead and employ a taser. The idea is that while the taser is cycling, have somebody restrain the person and deliver them to medics if the medics are present. We want to reduce the amount of fight possible. When you're restraining the person, think about increasing their ability to breathe. If their bloodstream is acidotic, the only way for them to off-gas that acid is through the exhalation of CO2. So you don't want to do anything that's unnecessary to restrict their breathing. If you suspect that the person you're dealing with is suffering from excited delirium, when you write your paper, please include as many of the excited delirium factors that we've discussed here as possible. The most important one, the key one that's going to help us in determining what type of medical crisis this person was suffering from, is going to be body temperature. The body temperature is one of the key indicators that seems to differentiate excited delirium from other drug-related medical crises. If you can, get the medics to take the temperature. If you have to send somebody to the hospital with them, simply ask for the vital signs. It's not a bad idea to go ahead and document in our paperwork what the blood pressure, temperature, respiration, and heart rate was. But the temperature is the main one we want you to get. If there's nobody there to take the temperature, then describe it. Touch them. Are they hot? Are they sweaty? Are they cold to contact? These are things that can help us later on if the person does die to figure out what was going on with them at the time. In developing this protocol, we've met with Dr. Kopis, and his feelings are that this is actually a medical crisis. If you encounter somebody who's suffering from excited delirium, he would like the opportunity to treat this person. If it goes bad and the person dies, he's much better equipped to articulate what happened to the person and why it happened and why this process actually started long before police ever came into contact with this person. As we've learned more about excited delirium, we're actually recognizing that our officers are encountering it on a more frequent basis. Fortunately, we have a great Medic One system here in our area. That doesn't mean that we're not going to have some bad outcomes if we don't treat these cases appropriately. We need to recognize the signs of excited delirium when we're encountering somebody, and we need to go ahead and activate the medic response to a violent subject if we suspect this is an excited delirium case. If the medics don't feel this is an excited delirium case, wonderful. They've screened it. We can now process them normally just like any other violent individual. But if it is a medical crisis, we've done everything that we can to deliver them to medical intervention, and if they die, it's because of something that happened to them before we encountered them, and we've done everything we could to save their life. The key is that as a police officer arriving there on the scene, you don't know how far along they are. You don't know if death is imminent or if it's still a couple hours away.
Okay, so pretty good video on excited delirium and the signs and symptoms and what to watch for. So when we're discussing, we do need to be aware of positional asphyxia. This is the main reason why we do not transport patients prone, either do police anymore. It's defined as inadequate breathing, respiratory arrest caused by a body position that restricts the breathing or the thoracic cavity. Okay, so when we restrain, we still are going to be in supine position. We don't do prone face down because of that risk. So when we're restraining, we need, like I said, you need to make sure there's 4 people at least, one at each limb. It does say leather restraints. Most of them now are those posy Velcro restraints, pretty strong. Until we're ready to take the patient down, stay out of that patient's reach. It's going to be a 1, 2, 3, here we go. You're going to act quite quickly. Usually it's going to be a trigger from the person that's talking to that patient. And once again, it's not the most fun thing, but it is for their safety as well as ours. Make sure your airway is adequate, patent, secured through transport, no negotiating on that. If they start spitting, you might have a spit hood or a surgical mask, or you can put a non-rebreather on them. You shouldn't have to tolerate that. Reassess, and your documentation is going to be very thorough on these behavior, or these, especially with restraints involved, these type of patients. So restraining a combative patient, we've got good old night watch here, and watch this one. And see how many people are with that patient.
We get a call from man down, code 2. He's got a very large hematoma to his head. Then he just got this like ungodly strength. Started fighting with us.
Stop, stop, stop. Combative patient delay.
So is he combative because he has a head injury? Is he combative because he's drunk? Is he combative because he's on a substance?
You mother, you're right, mother broke stuff.
Do you better come to tie it?
I'm not concerned about only myself. I'm concerned about this guy who has a potentially bad injury. That's why we restrain a patient. I don't want him hurting himself.
Y'all get his legs? Oh my God. He broke some of the restraints. He was that strong that he could just break the restraints.
Let's just get one extremity at a time. It's gonna be difficult to get him on the stretcher.
It took 6 of us to hold him down until Landon could successfully tie down all 4 extremities.
Okay. We finally get him all tied up, so we finally get him boarded.
We grab 4 corners, somebody hold the stretcher, and we're just all gonna go straight up. 1, 2, 3.
Takes multiple people to lift him because he probably weighs 280 pounds of solid muscle.
So everything I see so far is all facial. I don't see any trauma anywhere else.
We get him into the ambulance, and he's just continuing to struggle, continuing to fight.
Oh, look at that heart rate.
Just some oxygen, buddy. Breathe deep for me, okay?
Keep still.
Hold still, buddy.
Look at the size of his arms.
Is it in?
Yeah, we did. Code 3 to University.
Can you relax the sun?
There we go. Good job.
Buddy, what did you take tonight? You didn't do no drugs?
People, when we ask that in the ambulance, they think, you know, I'm gonna get in trouble. I'm not here to get you in trouble.
I'm just trying to help you.
I really want to find out if there's a chemical reason that you're acting like this, as opposed to this is a traumatic brain injury.
Hey, this is Landon on 3232. I'm an approximately 30-year-old male patient. We're coming in code 3 trauma activation. Possible 966 on board, not sure. Heart rate's 160, blood pressure of 168. We'll see you in a minute.
We're on the way to the hospital, and he is just struggling to get out of these restraints the entire time.
What's going on? You all right? You didn't do any drugs tonight.
Good hospital.
There's no way of telling what the outcome of this patient's going to be. If it's a head bleed or a traumatic brain injury causing his behavior right now, he could have lifelong defects from it.
He's talking, a little confused.
Hopefully it's just drugs. If that's the case, by tomorrow, it'll be out of his system and he'll just have a big bruise on his head.
My line's still good?
Yeah.
Did he admit to taking anything?
Nope, still denying it.
Be safe, be strong.
Okay, so that gentleman, we've got a lot going on. We've got, is it drugs? Is it the trauma? Is it the head trauma? What is going on with that patient? So if you look at it, we're still going to do our primary assessment. We're still going to do ABCs. The only thing that changed in the care of that patient is we had to restrain him. Okay, so you're still going to be doing the same types of patient assessment over and over and over again. But we had to have a little glitch there that for his safety and for the provider's safety that that we restrained him. So the Posey quick restraints is a quick video to see how these Velcro restraints work. You can kind of watch. We're not going to watch the whole thing, but
proper application of physical restraints is primary when you're dealing with someone who is potentially combative. What we're going to show you in this video is how to properly put on those restraints with patient care and safety of responders in mind. Okay, Todd Christensen, we're back with you again for the Crisis Intervention System in Michigan, where we have got paramedic Carson. And we're going to talk about applying those soft restraints to the potentially combative patient. Katie.
All right. So when we apply soft restraints to a patient, generally it is in situations where somebody could be either have the high potential to be violent, have already shown that they either are having violent tendencies, or are doing something to either harm themselves or put us in danger. So why we do this, we want to make sure that we are explaining to the patient everything we're doing, even if they're fighting us, struggling with us. Always communicate with your patient because this is not a very pleasant experience for this patient. So keep them as calm as possible. Typically when we go to restrain somebody, we want to gain control of an upper limb and a lower limb, and typically we go for the opposite. And that's to help prevent the patient from either being able to sit straight up and have both arms, kick with both legs, and then being able to roll or slide off the stretcher.
So we're talking opposites. We're talking like this arm, this leg,
yes.
And if Rob was a super potentially violent patient, this would be a 4 or a 5 person operation, not just 2 of us.
Absolutely. Typically, it's pretty rare that we do it with just a 2-person situation. It's typically only like in emergencies where we stop on the side of the road because something has changed or somebody has become violent and we don't have help with us.
Great.
So really, in the end, this is about patient safety and provider safety, and to do this with the least amount of force as possible.
Sounds good. So what we want to show you the proper application of soft restraints.
All right. So these are going to be our typical restraints that are on most ambulances. So our blue restraints are for the arms and red restraints are for the legs. If you can't remember in the moment, you can just look at which one is larger. The red is larger, so it will go on the leg. So let you hold on to these ones. Okay. So when we do this, typically we'll take one arm, choose one arm, and have one arm up, just like this. So I would get a hold of Rob's arm here, have my restraint open. So when we do this, soft side goes to the patient, so this is the padded side. So we're going to gain control of the arm. Your restraint, you want it to go not on the hand, not up here, but kind of on the smallest portion of the wrist. So soft side down to the patient, Velcro. Make sure you can get two fingers in to ensure that you are not cutting off circulation. Apply the third strap over top. So now we have control of this arm. So even if Rob tries to pull, I have something to have leverage on. So now when we go up top to restrain to the top of the stretcher, things you want to be careful of, don't overflex somebody's arm. So if Rob's arm were to stop up here and he didn't have the flexibility, don't force it, just try the other arm. Some people just have previous injuries, things like that. So never force somebody's limb past the point of their range of motion. So as we apply these restraints here at the top, the way that these stretchers are built, typically you cannot restrain this top arm to the frame of the stretcher without hyperextending somebody. So what we do is come to this movable part of the frame. So as we do this, you want to make sure that we're not looping the strap around that red handle there, or else he's going to be able to sit up, lay down, things like that with the stretcher. It'll move on us.
Now that's an important part.
Yes.
Anything that's red on the stretcher is movable, and that's not where you want to apply a soft restraint.
Correct. Okay. So avoid all the red things on, that is something that is unique to these Stryker stretchers, but typically anything red will move. So as we apply black to black, and you can give a patient as much extra leverage as they want or as you want. You can cinch this down even further to make it tighter, all dependent on how the patient's doing for you. So this one goes up top. So now Rob has some movement. You can kind of move around a little bit, not feel so constricted, but you still have control.
That arm's locked in.
Yep.
Opposites.
Yes.
Right down here. Okay, we've strapped down one arm. Remember opposites. Now we're going to strap down the lower extremity.
So with the lower extremity, same concept as the upper as far as placement goes. So you want to go on the thinnest part of the ankle here. So again, so upside down to the patient. Try to avoid placing it over clothing, things like that. Socks are okay, but that just helps avoid any constriction to them. So as you apply this, check 2 fingers in. You have your top strap that goes over. So now I have control of this limb. Yep. So we come down, and this gets placed on a non-movable part of the stretcher. So typically this black frame here. So again, black to black. And these ones can be as tight as you want. It all depends on patient mobility. And then that top strap goes over. So now we have our opposite limbs secured, and now we can move on to opposites on the other side.
Upper arm. Let's see if I remember how to do this. Okay. So we're strapping down opposites. Soft part to the wrist, and the skinny part of the wrist.
Yep.
Just like where you would apply handcuffs if you were a police officer. Lock that one down. And then I do black to black. Oh wait, 2 fingers.
Yep, there we go.
2 finger tightness, circulation. Solid part of the frame. Black to black. Just like that. We've locked in the black strap. Recheck circulation, and we're back to opposite extremity. Okay.
So again, soft part down to the patient. Try to avoid putting this over clothing. That helps also prevent movement of the patient. So soft side down to the patient. And then this top restraint goes here. And so over here, get a better look at where we're securing this to the stretcher. Comes down to this black frame here. So as we go, black side to black side. This is here. This comes up and folds right over. Don't cinch this down so tight that you constrict your IV pool, things like that. They can pop it up, and then if you need to use it, you don't want it to be stuck with a restraint.
So now that we have restraints on, we need to do a little recheck.
Yes.
What do we need to recheck?
So we go back through, now that we've gotten everything on, we want to recheck pulses in both wrists. Make sure that you still have good strong pulses in the wrist. So we'll come up, check a radial pulse. If you don't have pulses, the restraints either need to be loosened or readjusted. Typically, sometimes patients will pull on them and cause them to constrict on themselves. There's only so much you can do about that, but you do need to reassess about every 5 to 10 minutes, depending on what's going on.
Radial pulse, capillary refill?
Yep, so you want your capillary
Okay, so that gives you an idea how
refill to
posing
be
restraints
2
work.
seconds.
Okay. All right. So transporting to an appropriate facility, making sure to know that not all hospitals are prepared to treat behavioral emergencies. So make sure you're calling ahead, choosing the proper facility based on your protocol, on your hospital capabilities. Medical and legal considerations. So refusals, restraints, that is a significant risk for us. Make sure your documentation is very thorough. Make sure you're following your protocols. Usually the law will allow us to treat and transport patients against the will if they are a threat to themselves or harming others. family, whether it's, them or the community. Sexual misconduct in these behavioral ones as well. We, sometimes we can get accused of sexual misconduct. You're alone in the back with a patient. If you can have a same-sex partner attend to your patient, that's not always possible, but if you can, that's preferable, especially, with these behavioral patients. If then, whenever you have an aggressive or unusually violent patient, like you saw in these videos, it's no problem to have law enforcement accompany you to the hospital. Okay. Whenever you feel that you need that extra security, absolutely go ahead and request that. All right, so your critical thinking question of the evening is: you respond to an intoxicated minor, he's physically aggressive, he's threatening suicide, his parents say, well, can't you just treat him? But I don't want you to take him to the hospital. So how are you going to manage? What can you do for this patient? Right, I'm going to leave you at that. And that should take care of chapter 27.